I'd like to call upon the next speaker, Dr. Anna George from Apollo Hospital. Topic is until proven otherwise.
Good evening, everyone. I'm Anna George from Apollo Hospital. My topic here today is until proven otherwise. I'm presenting under guidance of Dr. Preeti M. Presenting a case of 36 years old female from West Bengal, housewife, presented with jaundice since 5 months, fever since 2 weeks, swelling of both lower limbs and face since 4 days. History of presenting illness. It all started with jaundice 5 months back, which was initially noticed as yellowish discoloration of eyes, later progressed to whole body over a few weeks. History of presenting illness. It all started with 5 months back with jaundice, which was initially noticed as yellowish discoloration of eyes, later progressed to whole body over few weeks. Total counts of 19,400. ESR was also high, 70. A total bilirubin of 12.1, direct hyperbilirubinemia with elevated cholestatic enzymes and elevated serum amylase and lipase. And they did an ultrasound abdomen which showed hepatomegaly of 15.2 centimeter. CBD was dilated 16 millimeter at porta and showing gradual distal tapering with few isoechoic areas at the distal part, suggestive of obstructive biliopathy. Pancreas was normal. And further they did an MRCP which also showed a distal CBD stricture causing upstream obstructive biliopathy with traces of few intraluminal sludge materials in the distal CBD lumen. The left hepatic duct, right hepatic duct, common hepatic duct, all were dilated. Pancreas was normal and the main pancreatic duct was not dilated. Then, yes ma'am. Yes ma'am. She has a history of cholecystectomy 5 years back. So then they proceeded for an ERCP in which the cholangiogram showed a dilated CBD with abrupt tapering in mid CBD, a stricture of approximately 2.5 centimeter in length, and bilateral IHBR dilatation. They did a breast cytology from the stricture, and 10 French into 10 centimeter straight plastic stent was deployed into the CBD beyond the stricture segment, and free flow of bile was observed. And the breast cytology report was negative for malignancy. It showed only few clusters of cuboidal to columnar cells arranged in flat sheets. And then post procedure, gradually her skin color improved and her eyes turned white. And on follow up, her investigations are shown as here. Total count improved and her total bilirubin levels decreased to 3.2, and later in July it decreased to 1.4. Even the enzymes also normalized. And then 2 months later, she went for follow-up at a higher center in West Bengal itself, and EUS was done. The findings of EUS were pancreas were normal, CBD stent was noted inside, and the proximal CBD was mildly dilated, and wall thickening was seen in the region around the mid CBD. And their final impression was mid CBD stricture with the CBD stent in situ. No biopsy, anything was taken. And subsequently, she underwent a repeat ERCP. The previously deployed stent was removed, and a cholangioscopy was also done, which showed a smooth stricture in the mid CBD with upstream CBD calculi. Biopsy was taken from the stricture, and then they placed a 10 French into 7 centimeter double pigtail stent. So the histopathology from cholangioscopic biopsy showed only chronic active inflammatory cells. There was no evidence of any malignancy. And the lab investigations done at that time, CA99 was normal, and serum IgG4 levels were elevated, 1200. So the patient was told to follow up as having a benign disease, not any malignancy. Then now she presented to us with fever and chills for 2 weeks and jaundice since 5 days. and progressive swelling of both lower limbs and face since 4 days. There was no history of any oliguria or frothing of urine. In past history, there was no history of diabetes, hypertension or TB, and she had undergone laparoscopic cholecystectomy 5 years back with history of pain abdomen, and it was done electively. Discharged on post-operative day 2, and the histopathology was chronic cholecystitis. There was no significant family history. Personal history: diet was mixed, appetite was reduced, sleep was also reduced, bowel and bladder habits were unaltered, and last menstrual period was 1 month before. And coming to general physical examination, after admission, the patient was drowsy, but she was arousable, moderately built and nourished, BMI of 25.9, pallor was present, she was deeply icteric, bilateral pitting pedal edema was present, there was no clubbing, cyanosis or lymphadenopathy, or no cutaneous markers of malignancy. Vital signs: she was tachypneic with a heart rate of 110, tachypneic with respiratory rate of 24, and tachycardia was also there, and BP was normal, SpO2 was normal on room air. Systemic examination: per abdomen, abdomen appeared distended, but umbilicus was inverted. There were no dilated veins. Hernial orifices were intact. On palpation, right hypochondrial tenderness and guarding was present. Hepatomegaly was present 12 cm below the right costal margin, which was tender but firm in consistency, smooth and rounded borders. There was no splenomegaly. On percussion, there was no fluid thrill or shifting dullness. Liver span was around 22 cm. Auscultation: bowel sounds were present. There was no hepatic bruit. Other systems: CNS, she had a flapping tremors. Plantar was bilaterally flexor. And the lab investigations with which she presented are: HP was 7.7, total count of 60,300, and which was neutrophilic predominant, and a platelet of 7.22 lakh, and a total bilirubin of 16 with direct component of 13, and ALP of 309. And then peripheral smear had neutrophilic leukocytosis with left shift. No blast cells. Leukemia reaction. And we proceeded for his CT abdomen since she did not have any CT images which were done outside. So in these images we can see gross hepatomegaly with multiple cystic lesions suggestive of cholangitic abscesses. We can also see the CBD stent in situ, and gross IHBR dilatation was also seen. And they had also mentioned about the proximal CBD was 2.4 centimeter and with abrupt narrowing of the distal CBD. Then we took up the patient for therapeutic ERCP, and the previously placed CBD stent was removed using a snare, and CBD was cannulated and pus was seen draining out of the ampulla. Balloon troll was done. Biliary brush biopsy was done from the mid CBD stricture, and 10 French Tannenbaum stent was placed across the CBD and pus was seen draining out. Post ERCP, the patient's sensorium worsened, and she was intubated and mechanically ventilated. Serum ammonia was elevated 167, and we had started her already on anti-encephalopathy measures from the time of admission. Blood culture had growth of ESBL E. coli and Klebsiella pneumonia, and which was treated with injection imipenem with cilastatin and injection fluconazole. 3 days post ERCP, she developed high-grade fever spikes. Repeat blood cultures were sent but were negative. But the patient's sensorium was the same. She did not improve. Then neurology opinion was obtained, and MRI brain was done, which showed diffuse cerebral edema. Then they suggested 3% saline. And 6 days post ERCP, her GCS improved and she was gradually weaned out of the ventilator. So this is the pattern of her labs following admission to our hospital. On admission, her total count was around 80,000, which gradually decreased to 60,000, and at the day before discharge, her count had come down to 24,000, and the total bilirubin was 16.8 initially, which came down to 5.6, which favor neoplastic etiology. So the message which we want to convey by presenting this case is that in any case of biliary stricture, we should have a high suspicion of malignancy until proven otherwise, definitely. And the patient was discharged with a plan for Whipple's procedure on follow-up. Thank you.
Would you have recommended a PTBD in this patient instead of an ERCP and just internalize it?
No,
The patient
because
is very sick.
no, ma'am. On presentation, she came to the OP actually.
No, your choice between PTBD versus ERCP in this patient.
At the day of presentation, she was conscious oriented with.
I'm asking you the
Yes, ma'am.
indication for PTBD versus ERCP.
If the patient is unstable to undergo ERCP, then we'll have to consider PTBD.
So you think the stent was blocked? When she came, she was in sepsis.
Yes, ma'am.
And there were multiple pyogenic abscesses.
Abscesses.
So in that situation, you think patient is very sick or not sick?
Patient
I'm
is
just asking,
sick. Yes, ma'am. Patient is
what
sick.
would be the recommendation for a PTBD? And your CA 19-9 in inflammatory process, we don't attach importance at all.
Yes, ma'am.
And atypical cells, most of them are all desmoplastic tumors. So you may need a spyglass stand to correction, but others who are into this can tell us whether a direct look into the biliary tract would be more informative rather than going for just a brush cytology and giving atypical cells. They're all desmoplastic, and you'll hardly ever pick up. What will be the yield rate of a malignancy? They're all stricturous desmoplastic tumors, the biliary tract. So less than 10 or 20% only you'll pick up malignant cells.
Yes.
Unless you do the other two, FISH and the other DIA. There are two other procedures that can be done. So role of spyglass, I think some of you can tell.
Spyglass is a good option, but unfortunately, since it's a distal CBD tumor, we have difficulty in placing the mid CBD. We can do a spyglass, but not in cholangitis, because in cholangitis we infuse. Yeah. Definitely. No, I mean, for spyglass, a better option than brush cytology. The evidence shows that brush cytology, as you rightly said, so yields only 20% of malignancy. Brush cytology combined with spyglass heals more than brush cytology alone.
If you have a stricture which is 2.5 centimeters in length, straight away you see strong suspicion of malignancy. And I think even earlier you should have looked for malignancy rather than to.
Cholangioscopy and.
Okay.
The reason we presented this is spyglass was actually done outside, and it did show a smooth narrowing of the CBD just distal to the insertion of the cystic duct. It was done at an expert center, and biliary biopsies were taken, multiple biopsies, it was negative. And the pathologist, I have discussed with the pathologist regarding this brush biopsy, and she's categorical that the cells are atypical. The reason we only picked this is because the patient had been told that this biliary obstruction is benign. They had a high IgG4 outside, so the gastroenterologist had told them that possibly this is benign, come back for a stent exchange, we will restudy you. So they came with the hope that it was benign.
To me, it is actually a low cystic duct insertion and an inadvertent partial clamping causing a stricture at that.
Ma'am, the difference is 5 years.
What is your?
5 years.
Yeah, it's a slow stricture. We have no follow-up thereon. To me, malignancy, unless it's indeterminate stricture, unless we have a foolproof with a spyglass, a repeat, I think to go for Whipple's, I stand to correction.
Spyglass was not repeated.
Here she was too sick to undergo anything, so we had to just decompress the
spyglass
wound.
negative.
I'm sorry, sir.
After this atypical cells, was the spyglass done?
No, sir. She had a very torrid course actually. Post ERCP, she had a very torrid course. In fact, it was even difficult for us to wean her off the ventilator, and I think the last thing on our mind at that point.
No, you send the patient home and then she's coming back for Whipple's.
No, she's
But
coming
before-
back.
Yeah.
She's coming back for Whipple's because, I mean, the biopsy did seem.
The madam's contention that atypical cells could be desmoplastic. So are you going to go for a spyglass before you subject her?
You can't go for a Whipple's
In either case, I think this patient has been followed up quite some time elsewhere. Without any diagnosis, the cause of the structure was never established. So one, if she was...
Just asking, are you planning for a spyglass when she comes back for the surgery? No.
So in either case, if a stricture which needed recurrent stenting, so I think at some form they should have had a surgical consult or a multidisciplinary discussion, because be it benign or malignant, it would have probably some form of hepatic angiostomy with resection, without resection would have been useful. Since now it is a mid-CBD stricture, it would be good to review the imaging to see if we can get away without a Whipple's and a bile duct resection. In that case, we will get both the diagnosis and this. Because the only MRCP you said was distal CBD stricture, but thereon in the further discussion. Yeah. So, okay. So if feasible, hepatic angiostomy with resection or Whipple, but then we'll have to be prepared to say that it can come out as a negative pathology. So that we have to, if it's a good risk patient, we explain that, because we've had situations where we have gone with atypical cells, and in the final Whipple specimen, it doesn't come. Benign. So it has to be a multidisciplinary discussion.
So we'll have a raise of hands. How many will go for spyglass, and how many will directly go, opt for surgery? Okay. I think, okay. Thank you, Anna.
Thank you.